Good afternoon, everybody. Welcome back to the latter part of the afternoon portion. Thanks to the speakers from before. Again, this is kind of our interdisciplinary portion, and we've had several speakers talk, and we will be proceeding with the panel discussion involving those same speakers. Before we get started on that, I did want to announce the name draw for the second draw for today. The winner is Jan or Jane Aikens. She's a winner of a $75 gift card to Rocky Mountain Soap Company. Please email team@PainAB.ca to confirm that you're still here, and we'll get that off to you. All right, so this latter part is kind of the interdisciplinary portion. There is a difference if you've never heard of interdisciplinary, multidisciplinary. Multidisciplinary simply means there's a number of different disciplines involved in your care. Interdisciplinary, when we look at it, means that each of those members can communicate with each other. And so we've set up a panel discussion like this to almost mimic that. And I'm going to be inviting some of the speakers back. So first of all, we'll welcome back Leung. You can pop up as I say your name. Emilie Brown. Cheryl Crow. Dr. Elisabeth Saxton. And then Dr. Darren Gray. All right, so welcome back. Thank you very much for joining us back again. So the STEM, for those of you who are in the morning, we're actually using the same patient in the morning as we are going to be doing this afternoon. And basically the idea for the first part is we'd like to kind of give the panel an idea of this patient that we're talking about. And for those of you who may be just doing the afternoon, I'll kind of repeat some of that information. And then I would like for each of them just to take, a couple of minutes or so to kind of let them know how they would be able to help this person in what way, and then to have a bit of a discussion of how each discipline can actually help each other and how that might work. At the end of that, then we'll definitely take some questions. I'll answer take some questions from the rest of the participants that are still here. And then after that, then I might answer some more, pose some other questions to the panel that we've had that weren't answered from the earlier discussions or the earlier presentations. So as far as the STEM, so again, we are talking about Sarah. So Sarah is a 55-year-old woman who is working full-time in corrections, and she's had some chronic pain for about a year into her hip. After further assessment, it has been confirmed a diagnosis of hip osteoarthritis. Some of her background information: she was actually a quite active individual, has always been quite active, enjoyed outdoor activities, having time to go for daily walks, and things of that nature. Okay. She has already seen a massage therapist, which is what kind of prompted investigations and things like that. As far as her work, she works in corrections. She uses a lot of stairs, many stairs. She is married. Her husband has actually been laid off from his job as a baggage handler. Finances are tight. They have 2 children, 15 and 17 years old. And there are some relationships issues with her husband. Mood is actually quite low, and even her 17-year-old has been struggling with some mood issues. So that's kind of the STEM. So I would actually invite the different members. I'll kind of call on you just to see how you, just to kind of give your 2 cents as far as how you might be able to help this person with their arthritis or what's happening with that. 2 to 5 minutes, because there's a short thing. And then at the end, we'll just try to see how we could all work together to help this patient to move forward with things. So I guess some of the, if we start with some of the easier things when we look at it, I know medications tends to be one of those things as far as, one of the first things people look at as far as helping, especially since some of the medications that Dr. Leung has talked about is actually available over the counter. So if I could invite you, Dr. Leung, to tell us about the medications aspect and how this could help this particular patient.
Sorry, that was me that you're talking to. Sorry.
Correct. Yeah.
Getting the Zoom up. So just from a background perspective, then I did have a list of medications for this particular patient, but obviously they're is more to just manage the pain component of it from the over-the-counter medications we talked about, from acetaminophen to ibuprofen and naproxen sodium. Now, there are other medications when you talked about her mood and probably anxiety. Is also medications to help treat that, which overlap into alleviating some of the pain, as most people know. So it's not just strictly pain medications that we're dealing with here, but other aspects of obviously mood, anxiety, and so forth. Obviously, from a functionality perspective, good easy rules of thumb obviously is using the least amount of medication to alleviate the pain discomfort, to make sure he or she, in this particular case Sarah, has day-to-day function, and obviously the ability to exercise and get outside and do some of the things obviously will help as well with mood and anxiety as well, which certainly can help alleviate some of the symptoms of pain as well. So maybe what I'll do is not having a list of medications and what she's tried and what she's currently on, I can kind of jump in when he or she has some questions and so forth, and I hear from some of the other practitioners first.
Great. So maybe why don't we move to Emilie, if you're able to kind of comment. So again, have her with arthritis. Is there kind of just a rough idea or some specifics you would either educate her on, or some exercises you would prescribe?
Yeah, so I think for this patient, as you've already kind of touched on, I think that education piece is going to be very, very important. So, educating the patient on exactly kind of what that diagnosis means, and then in terms of what the prognosis looks like as well. I think from an educational perspective, I think educating them on how important maintaining an active lifestyle is going to be in terms of managing this patient's symptoms, as well as prolonging, or I should say, like, decreasing how much the prognosis is going to then like evolve if you have more of like an active based treatment behind it. I think from a physiotherapy perspective, once that educational piece is taken care of, and once the patient has a really, really good understanding of kind of what they're looking at in terms of osteoarthritis and how important maintaining that active lifestyle is, I think, educating them on identifying areas of weakness through like a physiotherapy assessment, and giving them exercises to really kind of focus on those areas, and to correct any sort of problematic movement patterns that may be increasing their pain would be really important at that time, as well as just individualizing that program to that person. So, I mean, this person seems to have a diagnosis of mild osteoarthritis, so that could look very, very different to someone that has a more severe diagnosis. And then again, just kind of reinforcing that idea of the importance of activity, and just like staying active kind of within their pain, their pain limits. I think oftentimes people are a little bit lost and a little bit confused as to what things are going to make their symptoms worse and what things may cause them harm. So just really, really educating them on things to avoid versus things to engage in from an activity standpoint.
Wonderful, thank you. Maybe on the other end of that, from a physical therapy, maybe to see how a psychologist could help. So Dr. Saxton, if you're able to give your 2 cents, please.
So I think unequivocally the education is huge, and based on what we heard from Sarah earlier, my other question would be, there's a lot of hats that she's currently wearing. She's got work, she's got mom, she's got wife, and all of them seem to be in a bit of transition. So I would definitely come back to nailing down what are your priorities in terms of your functioning. So figuring out, yes, we know that the stairs at work are a real challenge, and there's been some conversation even around disability. So looking at the work role, the life role, in terms of wife and mom, and then really identifying what's the most important piece for her. So giving her that space to find those priorities and create sort of a list of priorities for herself, and then to actually give her a chance to really check in with how she is doing from a mood standpoint. So it's great to know that she's still going to work. Those are all good prognostic indicators, but really checking in with, so how are you doing? So look at her roles, look at herself, and then ultimately figuring out what behaviors might need support in that change. So whether it's the exercise regime, whether it's pacing strategies, or even looking at whether or not there's any concerns around how the medications are being used, and looking at which of those behaviors we want to target.
Well, thank you. And to kind of bridge that gap between psychology and physical therapy, Cheryl, would you be able to to put your 2 cents in, please?
Yeah. I mean, definitely building on, what Dr. Saxton and Dr. Brown have mentioned. I would want to take a really thorough walk through the day in the life with her. So, how is she approaching things? And ideally, I mean, in the perfect world, this would take place actually in her home, in her real natural environment, and even at her workplace. Because then you could see how is she physically approaching the tasks in her life, whether that's, toileting, or that's, food preparation, because she is having some hand involvement. So can we, recommend any joint protection strategies or gadgets, to help her preserve her function, preserve her ability to perform meaningful activities. And we look at the environment and the match between the environment and the person as well. So yeah, what could be changed in the environment? And that includes the social environment. So the fact that her husband has having, decreased mood, and she is also having decreased mood. There's actually some really interesting research on the role of family members in self-management for chronic conditions, and that, the husband and the daughter having kind of a low mood could definitely be posing like a barrier to her feeling that kind of gumption or mental and physical energy to go out and like implement the activities that are in exercises that are being recommended. So maybe seeing, again, in the perfect world, could we find some sort of maybe physical activity the whole family could enjoy together? Again, I'm thinking maybe too perfect of a perfect world, but, and then the other thing is just, was reading, she had some anxiety, but it was managed through daily walks, traveling. So can we help her re-engage in some of those things, even with her hip osteoarthritis? So, pretty, again, like some overlap from what, Dr. Brown and Dr. Saxton said, but that's what I'd start with.
Great, thanks. So it's nice. So we have a patient who has hip osteoarthritis that they tried medications, because that's usually one of the first things that we'll try. Now went to physical therapy, perhaps saw a psychologist, an occupational therapist. Pain's still not under good control. Dr. Gray, how do you think you'd be able to help this patient in that situation, and she's not able to progress through her pain or function? Didn't log in, I can answer that then. So as an interventionalist myself, I do some of the similar things that Dr. Gray does. So when it comes to things like injections, again, it's kind of what Emilie had talked about earlier, using these passive modalities. And I would actually include things like medications and injections under that classification of passive modalities to be able to help them function. So while we can do these injections, one thing we could do is definitely do a diagnostic test, where I would actually do an injection into the joint itself, just some freezing to find out if their pain actually decreases. So the way we use those diagnostic injections, it's not meant for long-term relief, but if your pain actually drops significantly after you put that freezing in there, then we know at least that a lot of the pain that you're experiencing would actually come from the joint itself. So if it's coming from them, then there's the potential for us to take a look at things like cortisone or some of the other medications, some of the other injectates like hyaluronic acid or whatnot. Knowing, of course, that in some of these instances, the evidence may not be the best, but we also know that sometimes patients are willing to try what they can to help them function again. So those are some of the things that we could do from hip joint injections. And again, with any of these things, what we hope is that if they have any kind of pain relief, whether it's from medications or from injections, that this actually facilitates everything else that Emilie or Cheryl or even Elisabeth is doing, and from a medication. So sometimes, moods, as much as we like for them to have that mental health support, that sometimes there is a role for antidepressants, anti-anxiety medications. That just helps to facilitate. Again, it's that same concept of using a passive modality like an antidepressant or anti-anxiety to help with more an active therapy, which is something like what a psychologist would do. So now that we have, so this is kind of that interdisciplinary kind of approach. I know work personally with Emilie Brown here, because we have some patients who we work in an interdisciplinary setting, and we've often sat around the table discussing a specific patient and just saying, and what's really interesting in that setting is sometimes we all only know pieces of the puzzle. So I don't know if any of you who are watching have ever seen that kind of comic of an elephant, and there's blind people and they're each feeling a different part of an elephant. And then they simply ask, describe what an elephant is. And of course, one person says it's the really long, cylindrical, fleshy type of appendage. Someone else might be saying it's really large, there's hardness in there. So right now, with all of these different people involved in Sarah's care, they only really know a piece of the puzzle. So when we start to get together and everyone starts to talk with this patient, and we've actually found it helpful in our clinic to have the patient in the room at the same time, we actually start to get all pieces of the puzzle together. And when we all start to see what the pieces of the puzzle together, so we can take an example. So if we find that really she wants to be able to do stairs more, get back to her physical activities. Well, this is where Emilie will then say, oh, that's great. I know I can really help you with that. But then we may find that, but that's not the only thing that's stopping her. She actually has a lot of fear that her pain's gonna cause her to become more depressed or whatnot. And so this is where Dr. Saxton would come in to kind of help with that. And then as far as any other difficulties, because we're talking about that, then Cheryl can come in to kind of help with those types of things. And of course, with medications or injections, we can all kind of chime in with that. And so that's kind of the way I've seen kind of that interdisciplinary care or approach work. And it's been actually quite eye-opening. Like I said, you don't get the full picture until everyone's all around the table discussing this patient's care. Have anyone else have any comments in regards to that, or your experiences with patients, or have you had any experiences?
I can actually speak to something that I think, if I look back, even at my graduate training, you learn about a lot of things, and I very much feel like I never got enough of a take on two things: one, persistent pain, and two, the value of work. I think we know from the research that one of the best protective factors for both our physical health as well as our mental health is being at work and having a sense of meaning, even if it's unpaid work, but feeling like you have a sense of meaning and purpose in that work. And often when we have our little silos on, I think that's that work piece, which we can really get the support from both the physical therapy to be able to physically meet the demands, but also from an occupational therapy standpoint, being able to integrate, their insecurities, their fears, and supporting them in how to do their work differently in every setting, whether it's corrections, whether it's healthcare. I saw the value in that. And I just thought to myself, wow, they really did not do enough in my graduate training to highlight the importance of that piece. So I often will say, for instance, with someone like Sarah, it's clear that being the sole breadwinner is adding a lot of pressure. It's adding a lot of extra pressure, and she's thinking she doesn't know if she can manage at work anymore. So we got to find a way. Like this to me is kind of a really high priority for her, that she needs to feel like at least that's one thing that's going well, because it's all on her right now until her husband is able to return to work or find work again. So what can we do to get some job coaching and get some supports so that she can do this well and feel like at least this isn't something that she's worried is going to fall apart if she has to go on disability.
Great.
Help, Cheryl, help.
Oh, no, I'm just nodding and agreeing. Yeah, no, that's, yeah. And I think, there is such, like you mentioned, a mental benefit to, mental health benefit to being able to participate. And, I did notice in the case study, they mentioned that a doctor's note for work accommodations, and that was parentheses sedentary. So I don't know if that means they're asking for her to be sedentary, but we also don't want to go too far in the other direction, right? Like, and I'm sure Emilie can speak to this, if you become so fearful of movement and then you're not moving at all, that's also, not good. But yeah, maximizing her ability to participate in the work environment, again, through the combination of compensatory tools and remedial tools to help her preserve her, mobility and decrease pain, is definitely important place to start.
Great. Emilie, and do you have anything in this particular thing with talking about work now? So I think we have a bit more of a focus.
Yeah, so I think with that, and I think that that's kind of a good segue again, and just into like that, into the actual education component, being that, sometimes people might see certain things as being like modified duties or being like, modified hours and all that kind of stuff, but it's looking at whether or not those modified duties now are actually going to be conducive to that patient's recovery. So just as you had said before, sedentary might seem like it's a little bit less strenuous, but if that leads to kind of other things and kind of reinforces some of that like fear of movement, as well as like deconditioning and all that, we also have to look at some of the implications of that. And that's not to say that sometimes that moving someone into more of those sedentary roles isn't needed, because sometimes if there's like a safety concern or if there's going to be an exacerbation of symptoms or the like condition, then absolutely. But I think it is kind of important to kind of look at both sides of that. The other thing I was just going to briefly touch on, because it was kind of talked about earlier too, is, someone had kind of like mentioned that idea of like identifying the barriers within your own treatment plan for that patient. So for example, from like a physio standpoint, if that patient has a lot of mental health concerns, and it's quite kind of obvious with like your treatment plan that there's other things that are really, really contributing to that person's pain, or if the actual pain is then limiting them from being able to engage in more of the active rehabilitation that's going to lead to increases in strength and mobility and allow for them to function. I think just like being able to identify those and rely on people around you to kind of intervene as well to kind of help with that patient's overall management.
Right. Will, some of the things that I know when we've had some patients who are trying to return back to work, for example, they have a lot of concerns in regards to some medications that may actually cause a lot more drowsiness or grogginess. So when they want to take these medications, it may actually help, whether it's mood or for pain, but then now they're concerned because now they can't function at work. Can you comment maybe on how you might be able to help, or how some things you would consider in that situation, please? I think your mute is on.
Sorry, I just have to unmute here. So the timing of the administration of medications is probably equally important. And yes, there are medications that can cause some drowsiness, and some are more activating as well too, with respect to the whole gamut of antidepressants or medications to help improve mood and anxiety and so forth. So it depends on what the medication is, but switching them to the times of day when they need to remain alert and so forth is very important. So, I mean, it's obviously medication specific and patient specific. So even medications that are sometimes can cause drowsiness, they don't affect others as readily as other individuals. So, unfortunately, it is very personal and very patient specific. So, yeah, for sure, the timing of the day is equally important. And even I might even go into say, perhaps someone might have difficulty sleeping and so forth, and you give them a sleep med. If they have that hangover effect the next morning, so that generally, well, it could be a number of different things, but obviously the half-life of the medication or how long the medication stays in the body. I think I'm addressing healthcare practitioners and also patients too, but how long the medication stays in your body will also determine how long the medication will be effective, how long the side effects will remain with you. So in the example you chose was the amount of drowsiness. So for example, if you gave somebody a sleep med because they're having difficulty sleeping because of mood and pain and so forth. So if they get up the next morning, they're groggy, and I'll call it the hangover effect, not from drinking a 2.6 of vodka or anything else, but specifically medications. Usually sometimes that's a dosage issue in addition to the half-life of the medications or how long the medication lasts in the body. So there's little things that can be tweaked for sure, but a general rule of thumb, ideally patients who need to be alert, yeah, for sure, adjust them as necessary to the degree of drowsiness it's causing, and then the time of days when they need to be alert. So.
From myself putting on Dr. Gray's hat, from an injection intervention standpoint, I also know that when we do that, there's some things to consider. So for example, cortisone injections can cause a bit of a flare. We've seen patients where they have a bit of a flare up within the first 48 hours. It can actually last from 3 to 7 days. So if you're going to you're going to inject someone's hip, there is that potential as well. From a work standpoint, we actually do let them know that this is going to happen because they might have to take time off of work if they're going to have a bit of a flare up. Even for some of these other things like a radio frequency ablation, sometimes there's a bit of recovery for that. We do things like that for the back. And so some procedures that you have, there may be a bit of a recovery time for that too. So even some of these passive treatments, they're not without their own side effects or potential increases of pain or whatever the case may be. And that has to be taken into consideration because in order for the patient to be able to move forward with that, they're going to have to take some time off work or at the very least have a backup. So if they can't make it to work because of a flare up, they can actually have someone cover for them or whatnot. So that's good. Now, Dr. Saxton, I don't know if there's any specific questions. I know I have some here that you posted in regards to the platelet-rich therapy. I think one of the participants had asked specifically about prolotherapy as a form of regenerative medicine. Unfortunately, so even though I do injections, I actually don't do the regenerative part, so I can't really comment on that. So unfortunately, I won't be able to answer that one specifically today. But was there any other kind of questions that people are posting?
Yeah, so there were some other ones that came up. Some of them are really specific. And then I think we might be able to have more of a discussion. And obviously, if any of the panel wants to chime in, one of them was more directed for Will. How often should you apply something like a topical, like diclofenac? Sorry, I pronounced that totally wrong. They've heard 3 to 4 days for a month, and then you can moderate it. Is there a sort of standard?
Okay, so the topical medication, so an anti-inflammatory, for example, diclofenac is one you mentioned. Most of the studies, so I'm going to compare an oral preparation of diclofenac because it comes in supply stores and so forth as well too. But if you're going to compare the onset of action, so how quickly the medication starts to work with an oral preparation, there's immediate release, there's also sustained release and so forth. So I'm going to say, as a general rule of thumb, within about a half an hour to an hour, you're going to get some pain relief and so forth from a medication you take by mouth. So if you're applying a topical diclofenac, for example, some of the studies would say that somewhere around 5 days, give or take a day or two, you need the levels to continue to build up in the body before you're going to reach maximum benefit. So as a general rule, we would tell anybody who's getting a topical anti-inflammatory, whether it's ketoprofen or ibuprofen or diclofenac, for example, they should use it consistently for that period of time. So I'm going to say at least 3 to 5 days before they reach kind of maximum benefits and how much pain relief it's going to be provide for them. Does that answer the question on how long you have to take it? Or also, I didn't know if your question related to how many times a day the medication should be applied. So that's kind of.
It was both.
It was both. Okay, so the number of times a day is really determined on how long the medication stays in the body. So they talk about half-life, meaning how long does it take before the body eliminates the medication and so forth. So that is medication specific. So like a diclofenac, for example, is the one you chose was. So anywhere from 3 to 4 times a day is perfectly fine. And then, so after that, I'll say 3 to 5 day period, 7-day period of continued use, you can use it on an as needed basis if you choose to.
Perfect, thank you. No, that was great. There was another one asking about taking Tylenol on an ongoing basis for years. Is there any risks to that?
Okay, long-term use in the appropriate dosages. So as long as you don't exceed that, as long as you don't exceed the maximum dosages per day, which generally for an adult, we're talking about adults here, so about 4 grams per day, and especially in combinations with other medications, they'll usually try and throw in alcohol, especially because they know that both in combination can negatively affect the liver. But generally, over a long period of time, anything less than that maximum dose of 4 grams per day or 4,000 milligrams, you should be fine. So so as a general rule, yes.
So the next question I think is more targeted for Emilie and possibly Cheryl as well. And I'm going to do two questions at once because I think they're very much related. One is, are there any specific really common consistent exercises for someone who has OA potentially in their back? And then the second one is about how long, if you do have an injection, so I guess we'll throw Dr. Gonzalez in here too, how long do you cease exercising for?
Yeah, so I guess from a exercise recommendation, I guess it kind of depends on what area of the back. So if you're looking at more so thoracic spine versus lumbar spine, there's going to be differences there. Hard to say kind of exactly what exercise will be best for this, for like on this person, as it tends to be very, very individualized. I tend to kind of look at the person's like movement patterns, look at kind of what muscles are working effectively and what muscles maybe aren't kind of doing as much of their job as we like to typically see. And then I kind of base my treatment plan off of that. Cole's knows essentially when it comes to osteoarthritis, the more that we can provide stability for that joint, the better. And so, for example, if it's someone that has some OA going on in more of like the lumbar spine regions, we really, really want to be getting more of the core stability muscle groups as well as the glute stability muscle groups and the whole hip complex to kind of do its part just to kind of better support the spine. But the specifics in terms of what exercises in particular, that will just kind of depend because again, thoracic spine functions very differently than like the lumbar spine, but that whole principle of increasing stability around the area is going to be kind of the most important part. So hopefully that kind of answers that question.
Yeah.
So what about the delay of waiting to exercise post-injection?
So I think from that standpoint, I do in those instances kind of let pain be your guide. Not everyone's going to have a reaction to cortisone, so not everyone gets a flare-up of their pain. So if you do get a flare-up of pain, think of it just like a bit of a regular acute type of a flare-up because we just stuck a medication in there that's causing a bit of that flare-up, and let that kind of settle down. Once you feel comfortable, we still think that movement, we don't want you to be on strict bed rest, but actually just kind of gentle moving and then kind of gradually increasing that would be good. So there isn't really one answer to say how long you have to wait after cease your exercises after an injection, because it's very patient dependent. In regards to laser therapy, I'm not too familiar with laser therapy. I don't know if anyone else on the panel is familiar with that, but I probably would still classify that under, again, another kind of passive therapy. So passive therapies along with laser therapy, even acupuncture and things like that. In general, when they look at the research, there's a very short-term effect, and I think Emilie actually talked about that you can get a very short-term or temporary relief with these things, but then really we want to use that to facilitate more of your active therapy, so your exercises, your function, your return to work. So but as an actual kind of treatment, I don't know the evidence. I'm not too familiar with that, but I'm not sure if there's anyone else that could comment on that or not.
No, I'm not super familiar with laser therapy either, but I do totally agree that, anything passive, whether it's laser or any of the more passive modalities, I definitely also see their usage in terms of, if it's reducing your pain to the point that we're then able to engage in more of an active rehab plan, then I think there's definitely a place for them. But the specifics around laser therapy, I actually can't really comment on that either.
I see a question here also for Will, if you don't mind. They are taking Tylenol arthritis twice a day for years, and they find it really helpful. They're wondering if that's okay to continue doing.
Yeah, so there are a number of different products on the market, and it's very confusing, not just for patients themselves, but for healthcare professionals, because they keep marketing different things. But Tylenol arthritis essentially contains 650 milligrams of acetaminophen, which is the active ingredient in Tylenol, the Tylenol brand name. So it has a different release mechanism comparatively to the regular Tylenols that we all know that came out back in the 50s and so forth. But it contains 325 milligrams that's released almost immediately, and then the other 325 milligrams are released over a gradual period. So Tylenol arthritis, if you're only taking a couple of days, is perfectly fine, and it certainly doesn't exceed that 4 gram total for the day. So it's perfectly fine. You can actually take more than that. So you're well below the threshold for any potential side effects and so forth.
I also see some very physiatry specific questions, so I'll see if I can answer those. Someone has asked, can a person self-refer to a physiatrist to explore treatments? They have had challenges working with their physician for osteoarthritic treatment options. So as a physiatrist, we are the physicians, we're specialist physicians. So there is no self-referral process for that. Your family doctor would have to make a referral to that. Although I believe, correct me if I'm wrong, Emily, that a physical therapist can also make a referral at this point in time too to specialist physicians. Is that correct?
Yeah, I think it just depends on if you have a prac ID or not. So not all physiotherapists will have that prac ID, but if they do, then they do have some referral
Okay.
to pass who's there.
So that's another avenue where you can kind of go through, but normally it has to go through your family physician, or sometimes actually another specialist that you have that might be also be willing to do the referral. The other physiatry question was, how do you know when to refer to a physiatrist for osteoarthritis, or whether or not you should be seen by a rheumatologist? So with that, there are in a little bit earlier, I did talk a little bit about the difference. So a rheumatologist, like I said, they do have more, they can do a medical diagnosis, non-surgical, where they really look at kind of the systemic or even autoimmune reactions that your body can undergo. And sometimes it can be attacking a specific joint. Sometimes it can be affecting different types of systems. So rheumatologist is really good to be able to, definitely from a medication standpoint, if you have that more autoimmune component. And that's kind of where we tend to use a rheumatologist more than anything else, or for some of the more other specialized joint issues. So things like gout or gout arthritis or those types of things can sometimes use the help of rheumatologist. Where we come in as a physiatrist, we're kind of a you know, a bit of a, it's kind of like what Cheryl was saying, being a jack of all trades. We kind of bridge the gap between a lot of different things. So a neurologist really looks at neurology, rheumatologist looks at the autoimmune and just kind of the joint aspect of it. You have, you know, some sports medicine doctors will just kind of do MSK and sports things. And whereas a physiatrist, we actually have training in a lot of these different areas. We have some part training. We've attended and been to different orthopedic surgeries. We've trained under a rheumatologist for a few months. We've trained under a neurologist for a few months, internal medicine. So we have a lot of these different things that help us to, and I think, and I'm a bit biased, that from a pain standpoint, I feel like we're one of the ideal specialties to do that, because I can tell you if it's nerve, I can tell you if it's a rheumatological condition, I can tell you if it's a bone issue, or a joint or a disc issue. And with all of those things, I'm able to kind of figure out where the next best person to see. So if I really think this is much more of a neurological issue than anything else, then I might actually recommend that you go see a neurologist, because this is a much more of a specific nerve disorder. Or if they see me and I'm kind of taking a look at, I'm like, you know, this really, there's a more of an autoimmune or an autoimmune inflammatory component to this. I really think you should see the rheumatologist or whatnot. So when there's that confusion of who should be seen by what, I'm a bit biased, but I think a physiatrist is probably one of the best ones to go to, even right off the bat. So if you think it's neurological or not, just send them to a physiatrist, because we'll be able to figure out which is the best person for them to see, and then send them on their way, so that we potentially could actually reduce the number of specialists they see, because we can figure out where they're going.
Well, I was actually kind of curious, because we mentioned flare up, and we've talked a lot of today about strategies that are going to help overall. And I'm just thinking, one of the key things that maybe we haven't spent a lot of time talking about is that it's really key for patients or clients to have a flare up plan. So for them to have something that they can kind of go to on those days when the pain is really bad. So whether it's you know, a breakthrough medication or something that they could go to, or whether it's a strategy. I'm just wondering if everyone would mind sharing what they might recommend for Sarah's flare-up plan, what might be beneficial.
Yeah, I can start. I think it's a very therapeutic process to develop a literal, like I just call it a flare-up toolkit, but it could be just a plastic box or a basket, but literally putting the stuff in there, because when you're in pain, you get overwhelmed and you're like, oh my gosh, where did I put my stuff? So, you know, having those topical gels, of course, the things that you start with the things that you know have worked for you in the past. It could be, a heating pad, it could be a cold pack, compression gloves if the hands are involved. And using some mental tools as well. Like I honestly, in mine, I include some really simple mantras like, this too shall pass, or I can do hard things. Cause I think this is just something I've observed in a lot of people who live with pain. You kind of torture yourself sometimes to think, did I cause this? Or like, is it my fault? Or is there more than that? Is there something more I could have done or should have done? Like stop shoulding yourself, so kind of having some reminders. A lot of people have like a little set of, again, like a laminated set of mantras that they can use when they're in pain. And again, maybe a technological one, but is, having like an app on your phone, like Headspace is one that I personally like, that can lead you through a relaxation exercise that, can kind of help calm your nervous system down a little bit. And then the last thing I'll say, I used to be a pediatric therapist. So I think a lot of adults actually really enjoy sensory tools too, like a weighted blanket or calming like scents. Like maybe I have like a lavender scented weighted blanket. So, things that bring you comfort is also something to put in there.
Emilie, do you have any strategies?
Yeah, so I think for this, I think, when someone's going through a flare, I think, as from like a physiotherapy standpoint, I think identifying certain activities with that patient in terms of what tends to be a little bit more strenuous than others. So I think it's really, really important here to kind of identify that, not all exercise is going to be the same, and that, the benefits from all exercise isn't going to all be the same either. And so potentially kind of like finding the activities that are not going to trigger the pain or make the pain worse during those moments of flare. So looking at things like, if specific strengthening is going to impact their pain more. So maybe we look at things that are more like a cardiovascular exercise on those days, or more like more of a mobility program on those days, as well as potentially targeting other areas. So, I think it's just finding the things that on those more painful days you are still able to do to actually give you some relief and to be able to kind of improve the long-term strengthening and the long-term rehab plan without kind of flaring up those symptoms. I also think that during these times, if the patient can use more of those passive modalities such as heat and ice, as was previously mentioned, just to kind of help them get out of those bouts, as long, again, that it's paired with some of that active management for as much as we can, I think will be really important for that too.
Great. Will?
I think from a medication standpoint, I know I sell drugs for a living and push them out the door as fast as we can, but at the same time, we want to use as little as possible. So again, anything to kind of get them over that hump is what I'll say. And so, for example, we talk about acetaminophen and ibuprofen and so forth because they're so readily available. But for example, acetaminophen, they've done some studies on an extra strength tablet of 500 milligrams compared to like 1,000 milligrams, which is 2 extra strength tablets. And they didn't find the effectiveness of 1,000 milligrams any better than 500 milligrams acetaminophen as a single dose. So, some of those things, obviously to help them to get through, but obviously medications for sure, that's one of the easiest things, but I certainly would go with non-medication or non-medication type modalities to try and treat the patient, get them the hump, like you said, so hot, cold, whether it's a hot tub or massage or whatever the story is. I think that's first and foremost would be the choice.
I think I'm going to echo from an injection standpoint. I often find if they're in a flare-up, number one, it also depends on when your last injection is. So if we're doing cortisone injections and it's less than 3 months, I wouldn't recommend doing any of that. Again, recommending some of these other tools that they have. But even in patients who come into me and say their pain is really, really bad, quite often I find that if they have an injection in that state, you have the potential to flare it up. So even though cortisone might be great for them, we could actually be flaring up their pain even more so than what it already is. There is that potential for that. The other aspect is, when a joint becomes really irritated, the muscles around it tend to also get irritated. They kind of get tight, they get painful themselves. And so when you try to stick a needle into someone's joint and that needle has to pass through those muscles as well, not the most comfortable thing for them too. And even if you use a lot of freezing, once that freezing wears off, if that muscle isn't really happy, sometimes it can feel like it worsens the pain in that standpoint. So again, I agree with actually Will, like medications or injections, is that necessarily the first line treatment? Kind of really focus on some of these other tools that Cheryl and Emilie has. Dr. Saxton, did you have some things from your standpoint?
I think for me, one of the biggest things about flare up, and this is kind of championing what we've said all day, that it's about empowering the patient and the client, is that I want people to start viewing their flare ups and help them see that it is strength and it is survival, and to almost celebrate when you've gotten through a flare up. So look at it like I've kicked its butt, instead of looking at it like, oh, I can't handle this. So it's reshaping kind of how they're viewing that flare up, and being able to have reminders where they can look back on something and go, you know what, I got this. I've had this before. I'm more aware, and a lot of the things that they've done, either through using some of those toolkits, or whether they're having discussions with the rest of the team about what their pain journey looks like, what it presents like day to day, and being able to say, like, I know I've had this flare up. It's been a long time since I've had one, whatever it might be, but being able to actually frame it as part of their story, rather than identifying with it like this is me. So it's externalizing it, having a reminder, whether it's a selfie, whether it's a picture of your family about why we're doing this. And then the biggest piece would be to get them to stay engaged. So even during a flare up, it's about, so yeah, maybe we order pizza tonight, but still sit down at the table as a family. But maybe we don't need to cook tonight. So you don't have to go with these really, flare up by definition kind of sounds like an extreme. And sometimes we go with these dichotomous choices. So honestly, let's try and look at this like it's a part of the whole process. It doesn't mean that we have failed. It doesn't mean that we are done, or we are over, or we just tap out. It's how do we stay fully engaged in what we value and find those ways to modify it, so that at the end of the day, we can still celebrate, not when we've done things well, but when we've survived the really bad days too.
Okay, great. So paying attention to time, it's about 2:51. Did we want to start with closing remarks? Okay, I'll hand it back over to Dr. Saxton. Thanks you everyone on the panel for coming out and participating in this section. It was very helpful. I'm sorry that we couldn't answer all of the questions that were there, but hopefully this is not the last time we'll have a similar type of panel discussion, and then maybe in the future we'll have something very similar. So thank you all very much for participating in the panel discussion.
So I want to say a huge thank you to everyone who presented today. I know they aren't all still available. We want to say thank you to everyone from across Canada that participated in putting together this incredible content. And I specifically want to say a huge thank you to our incredible planning committee, my co-chair, Dr. 𝐒𝐂𝐂𝐑𝐈𝐁𝐄, Dr. Yvonne Hernandez, who has been helping us to feed all the questions, Dr. Sean Gonzalez, who has moderated as well as presented, Dr. Tian Yen, who again pulled together a lot of the stuff that we've brought together for content and was part of the role play, Patricia Vade, who was part of the presentations as well, even though she couldn't be here, she's trapped, and Samina Sana, who again was helping behind the scenes. Thank you to everyone on the planning committee, and most importantly, you have all done something as a person with lived experience. You have all done something incredible to just show up and do this for yourself today, and to take that really, really strong action to put your health and your management first. So thank you to everyone. Please make sure you follow us on YouTube. You will get links to the presentations as they go up if you have registered today, and if there is anything else, you can always hit us up at team@painab.ca. Visit our website, visit our Facebook. We are also on Instagram and Twitter. Thank you so much, everyone. Have a great rest of your night.